Okay, so to reiterate what was said earlier in the semester, we talked about the differing burden of disease across the globe, particularly infectious diseases, and how human populations, become immune from particular diseases. And then with the introduction of new humans into an area, as human populations move, as they migrate, they come into contact with new diseases and indeed spread disease throughout the globe as a whole. As we mentioned earlier, under the work of Jared Diamond, Jared Diamond shows that there are diseases which are associated specifically with the Old World, so so-called Old World, including Europe and Africa, and Asia, and diseases which are specific to the New World, the so-called New World, the Americas. And you can see here very clearly the difference in the historic diseases that ravage different continents, and indeed when you saw the introduction of new populations coming into the Americas, the disease incidence shot up fairly quickly, causing very rapid death in populations exposed. Historically, the bubonic plague, before it left Europe, the bubonic plague, also known as the Black Death, killed perhaps a third of the global population, where whole areas of the countryside were depopulated, essentially leading to the collapse of feudal agriculture. The diseases of rodents, fleas, carried the infection from rats to humans, and then from human to human transmission. In terms of smallpox, you have human to human transition, with the intense spreading in the New World with the arrival of Columbus. This is, of course, from Diamond's work, been discussed in the relative ease of Cortez attacking and taking the Aztec capital in Mexico. So I'm going to go through some contemporary issues with varying diseases. I'll start with malaria. The etiology of malaria is transmitted exclusively through the bites of a particular type of mosquito. The intensity of transmission depends on a number of factors related to the parasite, the vector, the human host, as well as the environment. Symptoms will appear in 7 days or more, usually 10 to 15 days after the infective mosquito bite occurs. Now, this is important because many of these same symptoms that are listed here are the same symptoms of Ebola. And with the outbreak through 2014, we see these same types of symptoms potentially being misdiagnosed, as shown in the October 2014 film by Vice. If not treated within 24 hours, the malaria can progress to severe illness and often leading to death. In 2012, there were 207 million cases of malaria, and this can range anywhere between 135 and 287 million, with 627 deaths associated with this. Again, this is a range between 473 and 789,000. This occurs mostly amongst African children. You can see to the right here the figures, some of the campaigns that have been going on looking to promote things like bed netting, taking proper precautions, and then drugs as well. There's also been a lot of discussion about malaria in terms of reducing malaria, reducing the number of mosquitoes through the use of pesticides such as DDT, which of course there are a number of health concerns, both in the larger ecology as well as human health concerns with the use of some of these chemicals. The trend, however, has been relatively successful with malaria. Increased malarial prevention and control measures are dramatically reducing the malaria burden in many places, and mortality rates have fallen by 42% globally since 2000 and by 49% in the World Health Organization African region. So there's been a real focus in the campaign there to reduce the overall mortality from malaria. And of course, anthropologists have been involved with this in a variety of different ways, from introducing bed nets, community acceptance of that, the use of drugs as well in the context of medical anthropology. I'd like to talk about HIV and AIDS. This comes from a World Health Organization fact sheet from July 2014. You can see the link there if you're interested. HIV transmission occurs through the exchange of a variety of bodily fluids from infected individuals, such as blood, breast milk, semen, and vaginal secretions. Individuals cannot become infected through ordinary day-to-day contacts, such as kissing, hugging, shaking hands, or sharing personal objects, food, and water. Now, it's important to point out this is the biomedical discussion, the facts about HIV transmission. However, there are a variety of beliefs surrounding HIV transmission, and we'll get into some of those in just a little bit. In terms of deaths, all-time HIV-related death is 39 million globally, and in 2013 it was an estimated 1.5, with a range between 1.4 and 1.7 million people that died from HIV-related causes globally. In terms of prevalence, there were approximately 35 million people living with HIV at the end of 2013, and Sub-Saharan Africa in particular is the most affected region, with 24.7, that range between 23.4 and 26.2 million people living with HIV in 2013. The incidence rate of HIV/AIDS, this is the number of people that are newly infected each year. There are in a range between 1.9 and 2.4 million, or what World Health Organization calls 2.1 million people globally that are newly infected with HIV during that year. Sub-Saharan Africa accounts for almost 70% of the new incidence of HIV infections globally. In terms of treatment, antiretroviral drugs are sometimes referred to by the acronym ART, can control the virus so that people with HIV can enjoy healthy and productive lives. In 2013, from World Health Organization report, notes the uneven distribution of ART, that 12.9 million people are living with HIV were receiving some antiretroviral therapy globally. 11.7 million of these were receiving ART in low and middle income countries, or 36%, with a range of 34 to 38 of the 32.6 million people living with AIDS in low and middle income countries. It's also interesting to note that not only along the lines of income and along the lines of things like GDP that matter in the global distribution of these products, but also along the lines of age, as pediatric coverage is still lagging. In 2013, less than 1 in 4 children living with HIV had access to ART, compared to 1 in 3 adults. So there's a lag with care for children overall. If you're more of a visual person, these figures come from 2011 from UN AIDS, and the number of people living with HIV globally in 2011 is 34 million, or was 34 million. Again, primary amounts here, you see 23.5 million in Sub-Saharan Africa, 1.4 million in North America, 1.4 million in Eastern Europe and Central Asia, and in South and Southeast Asia, 4 million people living with HIV. Adult HIV prevalence globally is at 0.8% of the global population. This is 5% of the population of Sub-Saharan Africa, 0.5% of the population in North America, 0.8% or 0.8% in Eastern Europe and Central Asia, 0.3% in South and Southeast Asia. New HIV infections in 2011, 51,000 in North America, 83,000 in Central and South America, 1.8 million in Sub-Saharan Africa, and 280,000 in South and Southeast Asia. You can see here again the disproportionate number of individuals that are being diagnosed with new HIV infections. And it's also important to keep in mind that these are ranges here, and the number of new, in terms of incidence, this would be the number that would be reported. In terms of AIDS-related deaths, in 2011 there were 1.7 million globally, with 1.2 million of those coming in Sub-Saharan Africa, and you can note here too the 250,000 that are occurring in South and Southeast Asia. So again, in terms of global distribution of the burden of disease, we see this very heavily situated in the context of Africa. So this has led to a number of different speculations about the cause, the origin of HIV and AIDS, and there have been a number of surveys that have been conducted in the United States, and Lyons, in his 2014 piece, The Genocidal Virus, Addressing Belief Among Students of Color that AIDS is a man-made disease, goes through some of the literature regarding surveys of African Americans, noting that a 2005 survey showed 1/5 of African Americans endorsed the statement that AIDS was a form of genocide against blacks. In a 1990 study of 1/3 of church members that was conducted as well also endorsed the statement that AIDS is a form of genocide against blacks. Lyons points out that this does not, education is not necessarily a contributing factor to this overall opinion, as surveys amongst college students have shown more similar or more in terms of the notion of AIDS as a man-made disease. The connections, as Lyons explores these between beliefs and past medical practices, certainly Tuskegee, the long shadow of Tuskegee, where 300 rural, poor African-American men were injected with syphilis. They were systematically denied treatment, some of these for 40 years, and the progression of the disease was traced during this time period. In a 2008 survey, individuals reported that there is a cure for AIDS. This was a widely held perception, but it is being withheld by drug companies for economic motives. And so there was pointing in particular to Magic Johnson and how he was able to live a very healthy life after diagnosis with HIV. Lyons goes on to discuss in the article the social perspective of disease, and he notes that epidemics cluster together because of the social position of those that suffer from them. And this is in line with Paul Farmer's work on the notion of structural violence. Lyons notes that the spread of HIV in Central Africa is actually what a couple of reports Lyons cites to report that the spread of HIV in Central Africa is an unintended consequence of mass immunization campaigns using non-sterile equipment. And so here you see an incidence where biomedical intervention for healthcare has actually been detrimental to the population as a whole. Lyons concludes with a notion that HIV, substance abuse, and violence in inner city populations all go together with one another, and notes further that if concentration of HIV in specific populations is shaped by policy, then the AIDS epidemic is man-made in that sense. There does not have to be a mastermind or a single set of individuals with malevolent intent to produce an epidemic that is genocidal in a broad sense in its effects. So what he basically goes in a very long discussion about is he comes back to this idea that there is some substance to the belief of AIDS as a man-made disease, at least in terms of the cultural, structural, social, economic environments within which people find themselves, and how the burden of disease is unequally felt by members of the population. Niehaus, in his 2013 piece, AIDS, Speech, and Silence in South Africa, discusses the use of speech and confession by a South African non-government organization, which is called Treatment Action Campaign, to transform the stigma of HIV/AIDS into a badge of pride. Residents of one community, Impalak, a village in the South African Lowveld, actively resist this narrative and this idea of coming out, this idea of speech and confession about AIDS, to go to the active use of concealment. And Niehaus is interested in why this happens, and so goes through and does interviews with 25 individuals within the community, and finds that many individuals note that it's better not to test for HIV antibodies and know one's status. And there's a number of reasons for that. Individuals say things like they don't trust themselves, that they would potentially be dead if it was found out.